Good morning, everyone, and welcome to today's webinar hosted by PYA. Today, we are continuing our Healthcare Regulatory Compliance webinar series with a presentation on 2023 Medicare Physician Fee Schedule Final Rule, Part 3. PYA is happy to present today's webinar on this important topic. You will have the opportunity to submit questions to today's presenter by typing a message into the question pane of the control panel. We will collect these and address them by email after the webinar. All of our webinars are recorded and released with a copy of the slides after the event. With that, I would like to introduce Lori Foley, Consulting Principal at PYA.
Hi, Laura. Thank you. Welcome, everyone, to our third Part 3 series of the Medicare Physician Fee Schedule Final Rule. My name is Lori Foley. I lead PYA's Compliance Advisory Services and spent a good bit of time digging into MIPS over the years from an operational and a compliance perspective, and have been following along with CMS's transitions as we look to some new payment models and new pathways related to MIPS, and we'll spend the time today looking at what they made changes for in the final rule, as well as various information to help you prepare for 2023 performance year related to MIPS. We will spend our time, just a quick brief overview, 2 slides related to background, related to MACRA as a whole, which led to MIPS. And then we will dig into 2023 MIPS with finalized changes. We'll be sure to hit all 4 of the quadrants that go into MIPS performance and scoring. And then we'll turn and spend some time on the MIPS value pathways. You might recall that that is the direction that CMS is indicating that they are taking MIPS for a variety of reasons. We'll talk about those a little bit as we move into that component. We'll also look at the alternative payment models and the implications that it has related to MIPS before we touch on scoring, reporting, and some key takeaways to help you prepare for 2023. So with that, let's just go ahead and dig in with some background. You might recall that CMS committed early on that they are very diligently moving providers towards the goal of promoting adoption of accountable care relationships in their quality programs. So with that key piece, they are trying to shift providers to really focus on quality, focus on cost savings to make sure that we improve the care for patients, but also are sensitive to limited resources from a cost and a spend perspective. So as part of its accountable care strategy, CMS has committed that they would like to, by 2030, have all traditional Medicare beneficiaries and most Medicaid beneficiaries in a care relationship that has accountability for both quality and total cost of care. Those include models such as the advanced primary care models, specialty episodic payment models, and then of course accountable care organizations, which many of you are already familiar with. They see the tactics there related to full engagement of providers. It requires some tweaking of programs, improving the benchmarking and performance measures in order to be able to do that. And the ultimate goal is to move providers along that spectrum so that they too are participating in downside risk. That transition has been a little bit slower, so they are taking some active steps to assist with that. You might recall that MIPS, the merit-based incentive payment system, came out of the Medicare Access and CHIP Reauthorization Act of 2015, or MACRA, and it focuses on these 4 quadrants where we are looking at quality, cost, promoting interoperability, which many of us still recall was formerly known as meaningful use, and then improvement activities. And there are some exceptions in different components for alternative payment models or APM participants. We're not going to spend time here on the basics, but do recall that MACRA was created in order to address the sustainable growth rate situation. If you've been in healthcare for a while, you might recall that for a period of time prior to 2015, providers spent some anxious time at the end of each year to see exactly how deep a cut would be forthcoming from Medicare on its reimbursement. And then at the last minute or early in January, there would be some sort of legislation that would roll back those cuts. And it created a little bit of a roller coaster. It created some delays in payment filing and the ability to receive payment for claims, because claims were held. Everybody knew that that process was going to occur. So part of the goal of MACRA was to put some predictability into the process. So year after year, providers could plan on what types of, they had support to make investments in the technology and the processes needed to improve quality, reduce cost as they provided care. So MACRA was passed to accomplish those objectives that bring that predictability and then further that transition from volume to value. Now, if you've been paying attention in the last couple of weeks, you know that despite this program, there's still been some variability. We had some last minute reprieves in late December related to the PAYGO reprieve. There was anticipated to be a 4.5% cut on Medicare reimbursement that was actually avoided via an omnibus bill. And so now going into 2023, we are still limited at that 2% historical sequestration. So obviously, it did give us a little bit more stability over the past couple of years, but you see it still kind of creeps its way into our day-to-day realities. With that, let's take a few minutes and we're going to dig into the 2023 MIPS with those finalized changes. Starting first with quality. I know I've stated before in these webinars and in our conversations related to MIPS, over the years, the weighting of quality has decreased depending on the reporting mechanism, but I still feel that quality takes up a good percentage of providers' time when they are working on reporting for MIPS. Despite all that, we have seen a finalization in 2023 of 70% data completeness for all of the quality data that has to be submitted. And that was actually finalized in the 2022 Medicare physician fee schedule. In the proposed rule, they did propose to increase that data completeness to 75% for performance years 2024 and 2025. You might recall that there has been conversation about increasing that even up to 80%. So I do anticipate that perhaps after 2025, we will see some increases further up to 80, 85, even perhaps 90% as this moves along. The only thing that might thwart that is the transitions to MIPS value pathways. There may be a little bit of a reprieve since we will have that new mechanism coming into play. This data completeness does not apply to the web interface measures. If that reporting mechanism was a tool that you used, you probably anticipated that it was sunsetting in 2022. As part of the final rule, they did keep that reporting mechanism, but it is now only available to Medicare Shared Savings Program, ACOs, for 2023 and 2024. After 2024, right now, it is planned to sunset for all providers unless there's another change in the rules. In the final rule, and for 2023, we have 198 quality measures. That includes 9 new measures, as you see broken out here. CMS made substantive changes to 76 measures and existing measures, and substantive changes is their terminology, so definitely something to have on the radar. As takeaways, we'll talk about the need to look at those measures so you understand what those changes are. They also made additions and removals of measures from the specialty measure set. And then they removed 11 quality measures and they partially removed 2 measures. When we look at the benchmark scoring for 2023, in prior years, measures were scored against a historical benchmark from a performance period 2 years prior. In those situations where a benchmark was not available, then CMS attempted to calculate a performance period benchmark. They finalized in the 2023 rule that all administrative claims will be scored exclusively against performance period benchmarks. So a little bit of a twist, an update there on the benchmark scoring. As far as high priority measures go, they expanded the definition to add that last bullet, the one in italics, and I'll comment as we go through. Where you see italics on the slide deck, that means where there was an update in the final rule. because some of this material is just capturing the information that you need for 2023. So in the high priority measures, they added the health equity related quality measures that are new in 2023. And that's consistent with CMS's overall commitment to improve its focus, really heighten the focus on health equity across a variety of platforms. They did finalize the new measures that were in the proposed rule. You see those outlined here. And then they also proceeded with the removal of certain measures. There were more proposed measures to be removed than actually got removed. So you see these four over on your right, measure 260, 261, 275, and 439. They ultimately retained. Those were originally proposed to be removed. But you can see the measures on the left that are now no longer available for quality reporting. The bottom two, measures 110 and 111, they removed from MIPS, but they did retain those in MVPs, in the MIPS value pathways. And I think they did that for a couple of reasons. These are easy to measure measures that a number of providers use. I think they're kind of fallback because no matter your system, no matter your processes, a lot of times this information can be gathered from patients and tracked in a meaningful way. I believe I shifted those to the MVPs as an inducement to encourage providers to consider that transition prior to its statutory requirement phase. If you are a user of MIPS, the CAPS for MIPS, that is a voluntary tool that you can use for capturing quality, unless you're in a MIPS APM. If you are in a MIPS APM, then it is a required quality metric for you to utilize and capture information on. In 2022, the CAPS for MIPS was updated to include on that last bullet. Prior, it was Asian language spoken at home. With the 2023 update, they expanded that to include Spanish language spoken at home and then other language spoken at home. And CMS indicates that their goal there is to capture language preference more accurately as a measure response pattern of patients with similar experience so that they can make more meaningful comparison across different MIPS groups. So whereas before it just isolated into the one language spoken at home, now it's broader and will capture many different languages for comparison purposes. Turning now to cost, recall that cost improvement scoring statutorily was required to begin in 2022. However, because CMS didn't calculate cost measures in 2021, all providers and clinicians will receive a cost improvement score of 0 percentage points for that 2022 performance period. They did finalize in the rule that a maximum cost improvement score of 1 percentage point out of 100 percentage points will be available for that performance period. So they retroacted that requirement to 2022 to meet, or that's standard to 2022 to meet that statutory requirement that it be defined. But going forward, we will see providers will have the opportunity, if they improve their cost score from one year to the next, to receive an extra percentage point for that improvement. So it's not just about measuring cost, it's about improving cost and getting some additional consideration in scoring for that improvement. Looking at the improvement activities for 2023, there are now 104 activities in 8 categories. Those 8 categories are unchanged from the past years. The 4 activities are heavily weighted towards health equity, CMSs, again, 6 health equity priorities for reducing disparities in health. Though one of them, the last one, the COVID-19 vaccine achievement, is also for meeting public health targets. The new activities were approved as proposed. The only addition is on that 4th measure for the vaccine achievement. They did add an exemption for situations where the vaccine is contraindicated for a specific employee. So there is a way to track that that component and still meet that improvement activity. There were circumstances where providers wanted to use that measure but were unable to do so because of employee contraindications. CMS also modified 5 activities, and then they deleted 6 activities, as you see here. And we won't go into the details, but wanted to call them out so that if those are activities that your practice looks at and your entity uses, that you are aware that you need to abort those and then identify new measures. The primary reason that these were targeted is CMS felt that these were effectively captured in other categories, so either in quality or in the improvement activities. And then they are, the PCI bleeding campaign was actually sunset for CMS as a whole. Shifting to promoting interoperability, CMS did discontinue, they had proposed discontinuing the automatic reweighting of this category for nurse practitioners, physician assistants, registered nurse anesthetists, and clinical nurse specialists. We typically get a lot of movement in the PI category, and CMS was evaluating the reweighting for these other types, and they did finalize that they will continue to automatically reweight this quadrant for the provider types noted on the right, including the location types of the ambulatory surgery center-based, hospital-based, non-patient facing, and small practice providers. This doesn't mean that the nurse practitioners, PAs, CRNAs, and CMSs are not eligible to apply for an exemption to have the promoting interoperability category reweighted. It just won't happen on an automatic basis. Part of the reason that CMS has made this change is twofold. They felt like as they evaluated data, nurse practitioners, PAs, CRNAs, and CMSs did not often report individually. They often reported as part of a group, so they kind of got pulled along with the practice and the entity on the PI category. And second, they, I think, kind of analyzed and wondered if they were really creating an incentive for groups to not invest in up-to-date 2015 technology. So they felt like they were actually incentivizing people to not adopt new technology. So they felt like making this transition would actually be helpful in moving providers along that line. They also, under the 2023 rules, under the PI category, finalized the ability for an APM entity to report at the entity level in addition to the individual and the group level. Previously, if a provider were part of an APM, the individual or the practice that was a part of the entity had to individually report, meaning report outside of the APM directly to CMS for its PI performance. This allows the APM entity to do that for all of its providers. It just gives a little bit more flexibility and relieves some burden for the individual and groups as they're going through that process. They also finalized changes to the public health and the clinical data exchange objectives. They put forth in the proposed rule 3 different categories. They broke apart the pre-production and the validation into 2 different levels of engagement, but based on feedback, they collapsed those into 2. So when you are reporting for your promoting interoperability category, you will have to identify where you are on the engagement spectrum. So are you in pre-production and validation, or have you already validated your data and you're, for all intents and purposes, have adopted that category? They also finalized the requirement that MIPS eligible clinicians may spend only 1 performance period at the pre-production and validation level. So in other words, they are allowing providers to report that they are at a preliminary stage of adoption, but indicating that they can't hang out there, if you will, for an undefined period of time. If you haven't progressed by the next reporting period to the validated data production level, then you would not get credit for that particular measure. They finalized the rule in that transition, but they did delay its implementation until the 2024 performance period. So that will be something, if you're looking at some transitions in your EMR and this PI category, you'll want to have that timing on your radar. You do have a little bit of an extra bit of time since it won't be part of 2023, but it will definitely be, it's already finalized and will be part of 2024. So it won't come back up for comment, if you will, or proposal. They also transitioned some of the other measures that were a part of the PI quadrant. They finalized, for example, the query of the PDMP, the Prescription Drug Monitoring Program. Previously, that was an optional measure worth 10 bonus points, but now it will be a required measure also worth 10 points. They expanded that as proposed to include Schedule 3 and Schedule 4 drugs, in addition to the Schedule 2 opioids that were historically required. And then they also added and finalized a third option for the health information exchange, and that included participation in the Trusted Exchange Framework and Common Agreement, the TEFCA proposal. So that was finalized as proposed without any changes. So this slide illustrates the scoring shifts from 2022 to the finalized 2023. As mentioned, you'll see the adoption of the query, the PDMP is being required, and the shifts to the other categories. And then note that the provider to patient exchange in the current 2022 category isn't going away. It's just carried forward on this next slide. Just for visual purposes, we broke it into the two categories. But this gives you a good overview of the categories and how PI is being weighted for 2023. No changes. Again, it was as proposed. There are some CMS did provide some FAQs as part of its 2023 information sharing. And so I thought I know we've had some clients that have part of the challenges in any year planning for PI is often surrounding the transition to a new EMR. First, I did want to call out that 2023, as previously finalized in prior rules, requires use of 2015 Edition Cures Update Certified Technology, so the 2015 cert, in order to meet this category. If you are transitioning to a new EMR in 2023, CMS did specifically call out that you are still required to report on 12 months of data and 70% data completeness. Now that's related to the quality measure, but it still ties in with the use of the using the EMR, acquiring that information, and then being able to submit it. And really, the way they lay it out is that you still have to get information from the old EHR, you have to get information from the new EHR aggregated into one single reporting for that submission. And if aggregation is not possible, then the measure score will reflect that inability to meet the performance period, as well as the data completeness threshold. So we've been talking a little bit about MIPS value pathways, and so CMS is committed further in their final rule, their transition to moving providers from traditional MIPS to MIPS value pathways and or MIPS alternative payment models. Recall that the goal is with MVPs is to allow for meaningful comparison among specialties, medical conditions, or episodes of care, while also reducing reporting burden for the providers and then ultimately improving patient care. CMS notes that they intend for this to become an only method of participation in future years. It had been referenced kind of in passing that as to exactly when that would be. We do have some information from the 2023 rule that kind of locks in their plans. But right now, the timeline is for 2023, performance years 2023 and through 2025, that individual clinicians, single and multi-specialty groups, subgroups, and APM entities would be working towards an MVP for all MIPS categories. For 2026, we'll spend a few minutes talking about subgroups, but by then, multi-specialty groups will be required to form subgroups based on specialty to again allow for better comparison across specialties. And then they will continue to add to the MVP list as this process evolves. One of the complaints that providers had related to participating with MIPS is at the end of the day, with our 200 plus quality measures and our 198 IA measures and all of those different components, there were almost too many choices to be able to make informed decisions. And then it also disrupted the ability to compare providers across specialties or across like groups, because you could choose something totally different from group to group, and then therefore you lost your ability to make a meaningful comparison. So the purpose here is really to funnel providers into more narrow channels so that there can be more meaningful comparison as things move forward. They originally proposed to use PACOS data for that specialty determination for single and multi-specialty groups, and I know you all appreciate the importance of PACOS and having it updated for data purposes, but they did ultimately finalize in the 2023 rule that this will be determined based on Part B claims. So providers won't have to do anything special. It will just be calculated in the background related to the types of claims and how they're processed. This is the first time, though, that we've seen this visual related to that transition from traditional MIPS to the MIPS value pathways. And you can see here across the top, this is excerpted from CMS's presentation and some of their QPP resources, where the traditional MIPS trajectory will continue to run till about 2027. We get to a future of MIPS bucket here. The MIPS value pathways pick up this year in 2023. They become available for use, and they are kind of going off here into perpetuity, along with the alternative payment model APM performance pathway, APP. Gotta love it when we use acronyms that we already use commonly in our industry. So APP will now have two different meanings depending on your perspective and what you're using that information for. But when we look at 2023, this is the first year that we can begin to voluntarily use the MIPS value pathways and the subgroup reporting. They will continue that implementation and development over these next couple of years. Recall that I just referenced that in 2026, subgroup reporting will become required, and that's for that performance year. And then here is where we really see notice that MIPS aims, that CMS intends to sunset traditional MIPS with future rulemaking. Again, they in commentary and such, 2027 seems to be the target year right now. We'll see how the MVP rollout goes and if that gets transitioned. But it is clear as you're evaluating your long-term strategy for your organization related to MIPS that this transition will be coming over the next couple years, and the way you have done it prior to 2023 will sunset. Related to these subgroups in the MVP process, registration to use the MVPs, it will open up on April the 1st, and you will be eligible to register your group through November the 30th or a later date. They've left a little bit of an open window there should CMS specify. You will, if you're using CAPS for MIPS survey, we talked about that just a few minutes ago, in order to use that tool, you have to register for CAPS by June the 30th. So if you are using that as part of your MVP, you need to be aware that you need to register for that CAPS survey for the performance year. You still have until November 30th to register your MVP, but you do have a step that you need to take in the meantime. When you go in to register, you would do that logging into the QPP portal the way that you do other updates and registrations. You would select the MVP that you intend to report on, and at that time you would identify one population health measure that is included in the MVP that your entity will be tracking, or your individual provider will be tracking, as well as the outcomes-based administrative claims measures that you intend to be scored, provided there's one available within the MVP. You can register on April the 1st. You can make changes all the way up to November the 30th. after November 30th, whatever you've entered for your registration will be what CMS is looking for from you. You cannot change your mind as you're going along the reporting process and ultimately report on an MVP that you did not register for. Related to that subgroup registration, again, that is for multi-specialty groups required in 2026, though optional prior to then, that will allow you to take a list of NPIs that are affiliated with a single 10 and break them into like subgroups, most likely via specialty. They included as part of the registration, you would provide that list of NPIs that fall under each subgroup. You would have to provide a plain language name for that subgroup for public reporting purposes. So it's intended to be something that patients would recognize and understand the meaning of that subgroup when they see it on Physician Compare. Include a description of the composition of the subgroup, so the types of providers that are being bundled in there. A clinician at the NPI level will only be allowed to register for one subgroup per tax ID number. So if you have a provider that works for multiple tax ID numbers, they may be in multiple subgroups, but within the single tax ID number, they will only be attributable to a single subgroup. So for example, if you have a cardiologist that's an internal medicine trained physician, you would have to choose either internal medicine or cardiology. It would not be both. And then CMS did finalize in the 2023 rule that they will use the initial 12-month segment of the 24-month MIPS determination period to determine eligibility for this subgroup registration. So recall from your experience and maybe prior conversations that a clinician becomes eligible under MIPS through a 24-month look-back period. There are two 12-month segments for that look-back period that determines whether or not a provider is eligible, and by eligible meaning required to report MIPS either individually and or as a group. So through this, CMS has indicated that they will use that initial 12-month segment, which is essentially 2 years prior to the performance period, plus or minus a couple months, in order to determine that eligibility. Again, the goal there is so that you can determine early who all will be part of your subgroup when you're doing that registration, and that there aren't changes that are occurring after November the 30th on that second period review that might subvert and kick a provider out of being eligible, if you will. For the subgroup scoring, CMS did finalize the administrative claims measures are scored at the 10 level and applied to all subgroups, including that foundational level, the quality performance category, and the cost performance category. There are no scores assigned to a subgroup that registers but does not submit data as a subgroup. So if you register as a subgroup and then ultimately just report at the entity, at the practice level, group level, or at the individual level, the subgroup registration won't trump you, but do recall we just said that you can't report for an MVP that you did not previously register. So as you see here, the Medicare physician fee schedule in 2022 proposed 7 new MVPs for 2023. Those were all finalized as established, and then they added 5 new MVPs with the 2023 final rule. Most of the revisions are surrounding the improvement activities inventory and adding the ONC direct review attestation requirement that was left out of that 2022 final rule when those 7 were originally proposed. The new pathways you see on the right, they relate to cancer care, kidney health, episodic neurological conditions. So for example, patients that have epilepsy, supportive care for neurodegenerative conditions. So for example, patients that have Parkinson's disease, and then a promoting wellness MVP. When we talked about the categories, I mentioned the foundational layer. This foundational layer applies to all MVPs, and this is where I mentioned when you go in and you do your registration, you would select the one population health measure that you would be scored on. CMS will calculate those measures through administrative claims and then add the results to the quality score. And then you would also choose from your performance period whether your group would be scored on a hospital-wide 30-day all-cause unplanned readmission rate or a risk standardization hospital admission rate. So one or the other you would choose when you register your MVP. Then you would also report on the same PI measures as under traditional MIPS, unless they qualify for reweighting for one of the other reasons that we discussed. There are, above the foundational layer, then there are the three components in addition to the traditional quadrants that we see through MIPS. So you would have 4 quality measures, one of which must be an outcome measure or a high priority measure if an outcome measure is not available or applicable to your group. This can include an outcome measure that CMS calculates through administrative claims if it's available within the MVP. Not every MVP will have that option. Moving to the IA performance category, again, 2 medium weighted improvement activities or 1 high weighted improvement activity, or the patient-centered medical home improvement activity would qualify for that category. And then CMS will continue to calculate performance exclusively on cost measures that are included in the MVP using administrative claims data. So again, nothing to report on cost. CMS will be doing that all in the background. There were some expansions within the MVP process to allow for input related to the development and the maintenance of MVPs. So CMS is expanding those opportunities to provide feedback on viable MVP candidates. So they may have had suggestions, they've determined which are probable to move forward, which are not viable. For those that are viable, they will post draft versions on the QPP website to solicit feedback. CMS will then review that feedback and then determine if any changes should be incorporated into that MVP before it hits proposed rulemaking. Separately, they have created this process and finalized it for revisions to existing MVPs or the MVP maintenance process, and really seeking to expand opportunities for providers to participate in that maintenance process. CMS will host an annual public webinar to discuss MVP revisions that have been identified. And then interested parties can submit recommendations for previously finalized MVPs by sending an email. You do that via email to CMS detailing the recommended changes. That latter bullet was finalized in the 2022 rulemaking. The first bullet related to the annual public webinar was finalized in this 2023. So a couple of takeaways from this slide in particular, as you look at MVPs, how they fit for your practice, where there might be the needs to tweak some or expand, you do have the ability to communicate to CMS and provide that feedback. It will be important that you are signed up and either receiving email notifications from your portal registration and or the listservs on the QPP website, because that's how these webinars, for example, would be made known to the provider community so that you could participate. There will be a good bit of information outbound and incumbent upon providers to be aware of that and participate as they deem appropriate. So shifting a little to the alternative payment models, again, in the big picture, remember CMS's goal is to transition providers from the historical MIPS participation to either MVPs as step one, and ultimately they really want providers to transition to alternative payment models. That includes risk-based, and that's where there's been that reticence and that slow movement. So you'll continue to see, I think, opportunities where CMS will take opportunities to encourage providers to begin to get comfortable with and ultimately make that transition. So a MIPS APM is an APM entity that participates in the APM under an agreement with CMS. So it is an affirmative agreement with CMS to operate an APM. And it bases payment incentives on performance at either the entity or the clinician level on cost and utilization and quality measures. So again, The goal to improve quality for patients and decrease cost for and utilization of services for patients, for healthcare in general, decreasing the Medicare spend. Part of that process, and in order to encourage providers to take some steps and move down that pathway, is the APM performance pathway, that APP that we referenced earlier. Its goal, again, is designed to reduce the reporting burden on providers. It also creates some new scoring opportunities for participants, and really, again, to encourage participation in the APMs. The goal, as CMS puts it, is to create a more stable environment to allow providers to start to move into a risk-bearing environment and alleviate concerns about reporting MIPS, especially if someone was in an APM and they weren't certain if they were going to meet qualifying participant status. And if they found out further in the process that they had not met that status, they couldn't rely on the APM reporting mechanisms, and then had to go back and be scrambling, if you will, in order to report traditional MIPS that they felt was prohibiting some providers from taking those steps. So that's the purpose of the APM performance pathway. Similar to our other categories, we've got quality promoting interoperability and improvement activities. It's available to MIPS eligible clinicians that are identified on the APM participation list or affiliated practitioner list in any MIPS APM on any of the 4 snapshot dates listed here. So March 31st, June 30, August 31st, and December 31st, the end of each quarter. So if a provider is listed on any of those dates as a participant or an affiliated practitioner list, then they can avail themselves of the APM performance pathway. They don't have to meet the qualifying participant status in order to use this mechanism. Some of the differences related to the MIPS APMs, I mentioned, excuse me, at the onset that over the years, a great deal of effort has gone into capturing data and reporting for quality, yet the weight of that score has decreased over the years. You see here there are predetermined measures for MIPS APMs, and right now the score is a weight of 50% compared to 30% for traditional MIPS without another reallocation of weighting, for instance. So the measures you see here are diabetes, depression, high blood pressure. We mentioned CAPS earlier as being required for some APMs. Those readmission, all-cause readmissions, and some additional measures that are required for MSSP ACOs. These are all predetermined. It's not that you're choosing from that inventory of 198 quality measures. You're using these measures in particular. For promoting interoperability, it uses those same 4 categories as traditional MIPS, and providers and participants can report individually, as a group, or as an APM entity, similar to our other conversation that was new in 2023. And then the APM affords the provider essentially a perfect score in improvement activities that has a 20% weight, and you get 20 out of 20 or 100%. In performance year 2023, really the participation in an APM counts as the improvement activity, so no additional reporting is required. Note, for all of these categories, the weighting can shift if you are eligible for some exceptions and or special statuses. So therefore the asterisk on that, and we'll look at that in just a moment. CMS also finalized in the 2023 rule, it removed a planned 2024 expiration of the 8% minimum on the generally applicable nominal risk standard for advanced APMs. They made that 8% minimum a permanent fixture in the rules. And then for the medical home model, they finalized the application of the 50 eligible clinician limit to the APM entity. Prior to 2023, the adjustment was, or the size limitation referenced the parent organization, which left it unclear and didn't really, it just became more clear and gives more options to leverage it to the APM entity itself rather than the parent organization. It just more tightly aligned how that functions in the day-to-day world. So looking at MIPS scoring, For 2023, as part of the final rule, they did finalize that facility-based MIPS clinicians are eligible to receive the complex patient bonus, even if they don't submit data for at least one MIPS category. That will be automatically assigned based on the complexity of the patient. A virtual group is eligible for facility-based measurement, provided CMS determines that that virtual group has at least 75% or more of its eligible clinicians meeting the definition of being a facility-based MIPS eligible clinicians. So there were some categories there as to whether or not a virtual group similar to a standard group, if you will, could be considered receive that consideration based on the complement of its providers in the virtual group. And so they did afford it that this characterization in the 2023 final rule. And then there were, again, some 2023 changes that were finalized in the 2022 rule, including removing that 3-point floor for measures that can be reliably scored, and then also removing the 3-point floor for measures that didn't have a benchmark or that didn't meet a case minimum. Now it gets 0 points, except for small practices, which are practices with less than 15 providers. They can continue to receive those 3 points. So just capturing it again here so you have it all in one place. That was not new in the finalized 2023 rule, and it was actually included in 2022 in preparation for 2023. So we talked about the various different ways to report. And so this slide, which comes from the quality payment final rule in a webinar that CMS produced, gives you a clear picture of the weightings related to each of the categories. So on the far left, you see the performance category, quality, cost, improvement activities, and promoting interoperability. The second column is the traditional MIPS, and that includes groups, individuals, and virtual groups. No change from 2022. So if you participate in and report traditional MIPS, quality will weight 30%, cost will weight 30%. Remember, that's a statutory requirement. When macro and MIPS came out, the government, the CMS was required to make those equal by a certain year, which was last year. So that remains unchanged. Improvement activities is at 15%, and PI, promoting interoperability, at 25%. If a provider reports traditional MIPS and is in an APM entity, then that quality shifts and increases significantly here to 55%. Cost goes to 0, improvement activity stays at 15, and then promoting interoperability picks up a little bit there at 30%. And if you are a provider who is using in an APP and using that APM performance pathway, again, individuals, groups, APM entities, no change from 2022. Weighting, quality is at 50%, improvement activity is at 20%, and promoting interoperability at 30%. And then I referenced that sometimes the weightings will shift if you have a small group exception, if you're non-patient facing, if you are the provider types that we discussed earlier under PI that automatically gets reweighted, like physical therapist or occupational therapist. This diagram here is the starting place, and then there are algorithms that indicate that if you are waived on this, then the weighted percentage rolls to X category. So you can map through the results of the exceptions and the special circumstances to know at the end of the day how much of your situation will be attributed to quality, to cost, to improvement activities, or PI. But this is the starting place for each of those mechanisms. When we are all said and done and wrap it together for final scoring, the performance year 2023 and the payment adjustment for 2025, the 75 points was identified for neutral payment adjustment. So as long as a provider attains at least 75 points, if they hit 75 points, they will have a 0 payment adjustment, really. They won't go up and they won't go down. If they score below that, then they will receive a negative payment adjustment between 0 and -9%, depending on exceptions, any exceptions made to reporting rules. Remember, it's supposed to be cost neutral. So Penalties are supposed to fund upside dollars. If a provider achieves higher than 75.01, they should receive a positive adjustment greater than 0%. And recall, if you may recall that in prior years there was an exceptional performance payment that was available. That was just for the first 5 years of the program. And so 2023 is our first year where we do not have any additional payment for exceptional performance. Everyone will be following this scale to some degree as we go forward with 2023. Looking at public reporting, there were a couple of finalizations that were included in the policy. They did finalize a telehealth indicator to report when a provider uses telehealth as applicable and technically feasible. The goal for that is so that patients can use the public reporting tools to identify providers that use telehealth and might help them choose clinicians who furnish services. So if the patient is seeking a provider who provides telehealth services, then that indicator would be available on Physician Compare. They also finalized a policy to publicly report certain procedure information or utilization data on those clinician profiles, again, to empower patients to find providers who may have performed specific procedures that they are seeking. So what are the takeaways? A lot of information, and again, as we have those regulatory updates, key things to think about as you are preparing your entity for 2023 and really beyond. Be sure to evaluate all of the available options and determine which pathway best fits your group for this year. You need to review those changes to quality measures and improvement activities. Look at what you did last year. Go find the specs on the measures for this year on the QPP website. Review them, compare, one side by side closely to make sure you've picked up on any nuances that are included, to make sure you don't inadvertently miss the need to change an operation, a process within your practice, or a way that you aggregate or collect data. You don't want to get to the end of the year and realize that the measure has changed in the way you've been doing it throughout the year, particularly for that 12-month requirement related to quality data. You don't want to be behind the 8 ball and not able to recalibrate. Again, it may require you to modify your operations. You may need to update how your EMR aggregates data and train your staff to make sure that everybody's recording it in the right place and they're clicking the right boxes and performing the right tasks. So you need to be able to stay on top of that so you can facilitate success. Be sure to continue leveraging your operational, clinical, quality, and information systems team members for best opportunities for success. Where we see some struggles is where it really is an interdisciplinary, multidisciplinary approach required to really be successful across all of the quadrants and all of the categories. You might have someone in your organization who is the lead and the coordinator and or the owner, but at the end of the day, MIPS really does touch all of these components of a medical practice, and it really has to be integrated into day-to-day operations. It obviously captures and affects clinical and quality performance and relies heavily on your information systems, including your practice management system, your EMR, your different tools to make sure that you are tracking along and monitoring for success. If you are considering an MVP, be sure your vendor can support that data aggregation and reporting. There are some characteristics that were finalized in the 2023 rules that apply specifically to vendors. We did not go into that here today, assuming that most of our audience are providers, but you need to be in communication with your vendors to make sure that they are able to support these measures. CMS acknowledges that it takes time and energy and effort to get processes changed, programming changed, all of that to accommodate. And they did, as part of their rules, include some penalties for registries and QCDRs that are not keeping up to speed, that are not able to meet those initiatives. So you need to know what your vendor can do. Start to evaluate those APM options. We've been talking about APMs for years. And while we haven't had a set date that you are all required to transition by, it continues to hover out on our horizon. So, and for a lot of providers that have pulled the plug or taken the leap, if you will, and are in an APM option, it has alleviated some burden, perhaps. And they had to make some operational changes. They had to make some modifications, but I think there are many at the end that, both from an operational perspective, a data reporting perspective, and ultimately a financial perspective, have transitioned well and have become supporters of that. So as you evaluate what's right for your organization, again, team conversation based on those factors that we talked about earlier. And then be sure to develop your MIPS strategy for the next 2 to 3 years, understanding that traditional MIPS will likely be sunset. 2027 looks like the year for now. That may change as we go through, but we will continue to see a funneling of providers to the MIPS value pathways, the MVPs. We'll continue to see the inventory of MVPs increase, so everybody has something available to them. So it's an aggressive timetable to be able to get everybody on something by that 2027 or have those fully developed and vetted. But we certainly know, and CMS has been very clear about their goal and the direction that they are rowing. And I can't leave without some additional 2022 performance year considerations. We are recording this here in early January. So 2022 performance year closed December the 31st of 2022, but reporting for that performance year is due March 31st of 2023, probably a little earlier if you're working through a registry and a QCDR to do some troubleshooting and attributions and get approvals and such, but the government's window is March 31st. They have, for providers that have been impacted by COVID-19, extended the window to apply for an extreme and uncontrollable circumstance application until 8 p.m. Eastern time on March the 3rd, 2023. So little, probably about 6-7 weeks available to do that. CMS has said that they are not going to automatically reweight this to 0. So recall for 2022, if you did nothing, then if you submitted no information, then they reweighted you to 0 if you were in an individual practitioner. And they did the same in 2020, albeit a little bit late. So we weren't sure what they were going to do with the 2022 and the timing of that. So they have said we are not doing automatic reweighting. If you need reweighting because of COVID, then use the EUC application, and you can apply to have one or more performance categories reweighted to 0 because of your impact related to the COVID-19 pandemic. I have talked to practices that did that late in December. They applied for and received full reweighting, so they will go down to 0 and they will have a neutral adjustment. They won't receive a bonus, but they won't receive a penalty due to hardships. Most of what I'm hearing related to those hardships are continuity of staff. Across the nation, practices are still struggling with retaining staff, which has impacted their ability, candidly, just to see patients sometimes, but to be sure that they are monitoring and capturing all the information needed for measure support and reporting. So we're aware of practices submitting for that application for that exemption. If it's approved, CMS will reweight one or more of those categories. You don't have to do an across the board reweighting. If you just struggled in PI or you struggled in quality and you need that category reweighted, you can request that. It has the option, I think it's a drop down box where you put no COVID-19 pandemic, and then they will let you know that you have been, that you were approved or disapproved. As long as you don't then submit additional data, then that reweighting and that EUC will apply. Your score will be 0. If you do submit data, either through claims, if you're submitting data all along, if you're a small practice, or if you are, you submit at the end of the day your PI information, your quality information, it will be scored and applied as applicable. So if you get the EUC, make sure you don't accidentally undo it by submitting information without being intentional and having that be your intent. As always, CMS provides a number of resources on their website related to the final rule. And so you can go, the best way to access those is by hitting qpp.cms.gov. You can search for 2023 final QPP MIPS 2023, and many of these resources will pop up. There are a number of handouts and how-to guides. There are the updates related to the measure categories, and then webinars and FAQs and such that you can avail yourself of. As Laura mentioned, you're welcome to submit questions through the chat box. We will get those reviewed and answered back out to you. And then I failed to update this slide. We do have an upcoming regulatory roundup in the next 2 weeks related to the Consolidated Appropriations Act of 2023 and its impact on the healthcare industry. So watch for email blasts from PYA. We would love to have you attend that and see what's up with the CAA and its implications on your day-to-day operations and situation. With that, I appreciate your time and energy today, and I wish you well as you continue your MIPS journey. Please reach out and let us know how we can help.
Thank you, and thanks to our presenter, Lori Foley. If you have any questions, her presentation and contact information will be emailed to you along with a recording of today's webinar. Also, if PYA can provide assistance with audit, tax, compliance, valuation, or physician services, please call or email us. You may also visit our website at pyapc.com for more details about our specific areas of expertise or to subscribe to receive PYA insights. Please remember to stay on the line once the webinar disconnects to complete a short survey. On behalf of PYA, thank you for joining us and have a great rest of your day.